Rheumatoid arthritis. It's a chronic systemic inflammatory disease characterized by articular and extra-articular manifestations, most probably autoimmune. It is the most common form of inflammatory arthritis, 1 to 3% of the population. Etiology. It's still questionable, but many theories are suggested, such as autoimmunity, infiltration of synovial membrane with lymphocytes. Genetic factor may play a role, positive family history, HALA association, HALA DR4. Environmental factors such as infection with mostly viruses, such as Epstein-Barr virus, Mycoplasma pneumoniae. Pathology, articular, extra-articular, articular synovitis, thick, inflamed, infiltrated with lymphocytes and plasma cells. Pennus formation erode and destroys the articular cartilage, which leads to subluxation and deformity. The predominant infiltrating cell is the T lymphocyte, so diseases like HIV in which T cells are decreased will improve pre-existing rheumatoid arthritis, and this is the reason why rheumatoid arthritis is very rare in patients with HIV. Extra-articular, we have subcutaneous rheumatoid nodules in 20% of the rheumatoid arthritis patients. It's exclusive in seropositive patients. Central fibrinoid degeneration with inflammatory cells covered by fibrous capsule. Mode of onset, gradual, intermediate, acute, gradual, month, 70%, intermediate, weeks, 20%, acute, days, 10%. The typical onset is gradual polyarthritis, but it may begin with monoarthritis. Clinical picture, 1 to 3% of the population, female to male ratio, 3 to 1. General, fever, fatigue, weight loss, morning stiffness lasting 1 hour or more. The most important word here is morning stiffness lasting for 1 hour or more. Articular manifestations, 3D, distribution, description, deformity, distribution, polyarthropathy, symmetrical, peripheral more than central, so upper and lower limbs are more affected than the central joints. Affects mainly small joints, hands, feet, wrist joints, proximal interpharyngeal, metacarpopharyngeal, and wrist joints, ankle. The distal interpharyngeal joints are usually spared. The arthropathy is erosive, so it leads to deformity formation. Description, redness, hotness, tenderness, swelling, limitation of movement. Deformity, hand deformity, we have boutonniere deformity where extended distal and flexed proximal interpharyngeal joint. Swan neck, we have flexed distal interpharyngeal joint and extended proximal interpharyngeal joint. Ulnar deviation of the metacarpopharyngeal joint, Z-shaped thumb, flexed metacarpopharyngeal joint, and extended interpharyngeal joint. Carpal tunnel syndrome, telescope deformity, due to substantial absorption of the metacarpal and pharyngeal bone ends, which will lead to the extension or shortening of the involved fingers as a telescope. Then we have cricoarachnoid joint, leading to stridor and hoarseness of voice, atlantoaxial subluxation, spinal cord compression, paraplegia, tendon rupture, affecting extensors more than flexors, so this will lead to flexion of hip and knee, synovial membrane rupture, leading to Baker's cyst or popliteal cyst. Extra-articular manifestations, skin, subcutaneous rheumatoid nodules, palmar erythema, vasculitis, pallor, renal, amyloidosis, drug-induced glomerulonephritis from NSAIDs, gold, penicillamine. Cardiac, we have pericarditis in 30%, myocarditis, aortic regurg due to vasculitis, systemic hypertension, ischemic heart diseases. Chest, we have pleurisy and pleural effusion, interstitial pulmonary fibrosis, pulmonary infarction, pulmonary hypertension. Methotrexate leads to pneumonitis. Kaplan syndrome, rheumatoid nodules with pneumoconiosis, which is rare. CNS, chorea, neuropathy, myopathy, psychosis, depression, epilepsy. Cerebral vasculitis leads to stroke, and most importantly, we have atlantoaxial subluxation, which leads to spinal cord compression, leading to paraplegia. Carpal tunnel syndrome, compression of the median nerve due to hypertrophied synovium, which may be the first symptom of rheumatoid arthritis. Eye, we have conjunctivitis, scleritis, and when repeated leads to scleromalacia or blue sclera. Iritis is not common. GIT, nausea and vomiting, peptic ulcer, gastritis, pancreatitis, hepatosplenomegaly, abdominal pain due to vasculitis. Blood, we have anemia, microcytic hypochromic anemia, iron deficiency, or of chronic disease. normocytic normochromic anemia, autoimmune hemolytic anemia. Causes of edema in lower limb in rheumatoid arthritis may be due to 3 reasons: whether myocarditis leading to heart failure, pulmonary hypertension or IPF, interstitial pulmonary fibrosis leading to cor pulmonale, and nephrotic syndrome due to amyloidosis or drug-induced glomerulonephritis. Rheumatoid pleural effusion, characterized by cholesterol crystals, secondary empyema, pleural fluid glucose less than 30 mg percentage. There is a comparison between rheumatic fever and rheumatoid arthritis. Rheumatic fever, less than 6 weeks, affecting large joints and not erosive, unlike rheumatoid arthritis, which is erosive, affecting small joints and chronic disease lasting for more than 6 weeks. Investigations. X-ray. None of the X-ray finding is diagnostic. We have osteoporosis, narrow joint space deformity, and we must mention the deformity and describe it. Loss of articular cartilage and bone erosions develop after months of sustained activity. X-ray for chest show pleural effusion. Number 2, aspiration of synovial fluid will show antibodies, blood, decreased RBCs, anemia normochromic or hypochromic, increased YBCs, but it's only decreased in Felty syndrome due to pancytopenia. ESR and C-reactive protein are highly increased, and ESR may exceed 100 in severe cases. Serological tests. Rheumatoid factor is positive in 70% of the cases. Lupus erythematosus is positive in 20% of the cases. Antinuclear antibody is positive in 20% of the cases. Recently, anti-CCP, and its abbreviation for cyclic citrullinated peptide. Rheumatoid factor, it's an IgM against IgG. It may be positive in normal population, 4% or 25% of the elderly. Rheumatoid conditions such as Sjogren syndrome, rheumatoid arthritis, SLE, scleroderma, dermatomyositis, and non-rheumatic conditions such as infective endocarditis, myeloma, TB, HCV, syphilis. Value of rheumatoid factor in rheumatoid arthritis is helping in diagnosis, but it's not sure alone, and help in prognosis and for follow-up. We have 1987 ACR classification criteria for rheumatoid arthritis. The patient should have at least 4 of the following 7 criteria: morning stiffness for more than 1 hour, arthritis in 3 or more joints, arthritis in hand joints, symmetrical arthritis, and those 4 must at least persist for 6 weeks or more. Number 5, subcutaneous rheumatoid nodules, characteristic X-ray finding such as erosions, and positive rheumatoid factor. We have 2010 ACR classification criteria for rheumatoid arthritis. Definite rheumatoid arthritis have scores 6 or more. Patients with score less than 6 should be assessed over time, and it's divided into 4 parts: joint involvement with 0 to 5, serology 0 to 3, acute phase reactance 0-1, symptom duration 0-1, less than 6 weeks 0, 6 weeks or more 1. Acute phase reactance, normal CRP and normal ESR 0, abnormal CRP or abnormal ESR 1, serology, negative rheumatoid factor and negative ACCP 0, low positive rheumatoid factor or low positive ACCP 2, high positive rheumatoid factor or high positive ACCP 3. And high means more than 3 times of the upper limit of the normal. Pay attention. We have 0 to 3, not 0, 1, 2, 0 to 3. Okay? Joint involvement 0-5. If one large joint, such as shoulders, elbows, hips, knees, and ankles, 0. 2 to 10 large joints, 1. 1 to 3 small joints, such as metacarpopharyngeal, intercarpopharyngeal, proximal and distal, blah blah blah, 2. 4 to 10 small joints, 3. And if more than 10 joints with at least 1 small joint, 5. Pay attention, we didn't mention 4. The score is 0, 1, 2, 3, 5, and serology 0, 2, 3. Factors associated with poorer prognosis: male patients, insidious polyarticular onset, extra-articular manifestations, high value of rheumatoid factor, presence of HALA-DR4, functional disability at 1 year after start of the disease, radiographic evidence of erosions within 3 years of onset of the disease. Treatment of rheumatoid arthritis. The cornerstone strategy for management of rheumatoid arthritis is the induction of remission early before structural damage. General treatment. Rest. Complete bed rest is advisable in active disease. Articular rest by using splints will help to suppress synovitis in isolated joint inflammation. Physiotherapy. It can be started after the finishing of acute phase. Rehabilitation programs help in education of patients, minimize pain and swelling by using local heat, cold, or electrotherapy. Passive and active exercise program aim to strengthen muscles and preserve range of motion and minimize deformity. Medical treatment. Number 1, NSAIDs. They relieve pain and inflammation, such as aspirin, diclofenac, paracetamol, indomethacin, ketoprofen, celecoxib, and lornoxicam. Aspirin, 500 mg each 4 hours. Diclofenac, 50 mg 3 times per day. Paracetamol, 500 mg 3 times per day. Indomethacin, 50 mg 3 times per day. Ketoprofen, 100 mg 3 times per day. Celecoxib and lornoxicam, they are COX-2 inhibitors, cyclooxygenase inhibitors. Side effects are with mnemonic aspirin, A. Aplastic anemia, S. Salt and water retention leading to edema, worsening of hypertension and heart failure, P. Peptic ulcer, especially with COX-1 inhibitors, R. Rash, I. Induced bronchial asthma. I didn't make this mnemonic. I swear I didn't make it. N. Nephrotoxicity, interstitial nephritis, and rarely acute renal failure. Precautions. Never exceed therapeutic doses and never combine more than 1 NSAID. Avoid long-term use if possible. Number 2. Cortisone. Small dose of cortisone may be given, 7.5 mg per day. Systemic steroids are uncommonly needed nowadays. It may be used in high dosage in treatment of extra-articular manifestations, and the side effects are in the endocrine book. Analgesics and cortisone, they improve pain, but they don't prevent joint damage or slow the disease progression. Disease-modifying anti-rheumatic drugs. Group of drugs used in systemic rheumatic disease, not rheumatoid, aiming to minimize disease activity and progression. They are slowly acting. Their effect takes like 4 to 8 weeks to appear. Should be used as early as possible to induce remission and avoid erosive changes. Mechanism of action. The exact mechanism is still unknown, but we can assume that some has antimicrobial activity, such as sulfasalazine, inhibitory effects on the immune system, inhibition of lysosomal enzymes, phagocytosis, and prostaglandins. Number 1, we have gold salts, sodium orothiomycete. Dosage, 50 mg per week intramuscular for about 20 weeks, so the total dosage is 1000 mg. Side effects, DAHAP, I didn't make this mnemonic, hypersensitivity, depression of bone marrow and dermatitis, proteinuria. Precautions, stop if proteinuria is more than 2 grams per day, and stop if YBCs are less than 3,000 or platelets less than 100,000. Penicillamine, this decreases rheumatoid factor. The dosage is 250 mg per deciliter per day. Response within 4 to 6 months. Side effects such as gold, depression of bone marrow, dermatitis, hypersensitivity, proteinuria, plus SLE. Chloroquine, dosage 250 mg per day. Response within 4 to 6 months. Side effects, retinopathy, corneal opacity, but never cataract, and skin rash. Precautions, request fundus examination before use and every 6 months. Sulfasalazine, mode of action, antifolate, dosage 0.5 to 1 gram per day, then increase to 2 to 3 gram per day over few weeks. Side effects, headache, skin rash, GIT irritation, leukopenia, reversible depression of sperm count. Immunosuppressive drugs. Methotrexate. It is the most popular DMARDs. DMARD's disease-modifying anti-rheumatic drugs. Dose 7.5 mg per week, oral or subcutaneous or intramuscular. Side effects: anemia from folic acid deficiency, bone marrow failure, hepatotoxicity, pruritus, photosensitivity, pigmentations, pulmonary fibrosis, and interstitial pneumonia. Precautions: never exceed therapeutic doses. Regular monitoring to screen for serious complications such as CBC, left and KIFT, liver function test and kidney function test. Chest X-ray may be required as there is small risk of pneumonitis with methotrexate. You should bear in mind that penicillin and NSAIDs enhance its toxicity. Avoid alcohol and sun exposure. Avoid infections. Mouth sores may be reduced by folate supplementation. Leflunomide or Avara, new effective drug with rapid onset of action. Dose 100 mg per day for 3 days, then maintenance dose 20 mg per day. Side effects: diarrhea, skin rash, hepatotoxicity, and rarely bone marrow failure. Abasuprime dosage: start with 1 mg per kilo per day, then increase to reach 2 to 2.5 mg per kilo per day. Side effects: nausea, leukopenia, hepatotoxicity, and prolonged use increases the risk of lymphoma. Biological modifying agents like tumor necrosis factor alpha blockers, infliximab and adalimumab. These agents are used in severe active rheumatoid arthritis when standard disease-modifying therapy has failed, usually given in combination with methotrexate. These drugs block the action of cytokines, chemical mediators. The onset of action is rapid compared with traditional disease-modifying drugs, 2 weeks. Side effects: expansive and infections such as TB. Interleukin-1 blocker, anakinra. It blocks the biological activity of interleukin-1, including inflammation and cartilage degradation associated with rheumatoid arthritis. C. Intra-articular injection of cortisone. It's indicated when joints remain painful, despite general measures, and inflammation of the tendon, such as tendon Achilles. Side effects: infection, like septic arthritis, or rebound pain. Surgical treatment: synovectomy, arthrodesis, and joint replacement. Variants of rheumatoid arthritis. Number 1, Sjogren's syndrome. It's classified as primary when it occurs in the absence of another connective tissue disease, and as secondary when found in association with another connective tissue disease, such as rheumatoid arthritis SLE or MCTD, and I don't know what is MCTD. There is an association with HALA B8 and HALA DR3. Don't forget that HALA DR4 is for rheumatoid arthritis, while HALA B8 and HALA DR3 are for Sjogren's syndrome. Clinical picture: arthritis, usually non-erosive polyarthritis, dry eye, xerophthalmia, dry mouth, xerostomia, dry skin, dry vagina, lymphadenopathy. There is increased incidence of lymphoma, renal tubular acidosis, and Raynaud's phenomenon. Associated autoimmune disease such as myasthenia gravis, autoimmune hepatitis, thyroid diseases. Investigations: highest incidence of rheumatoid factor is found in Sjogren's syndrome, 90%, and it's very important for MCQ. Anti-RO, anti-LA antibodies. Anti-RO is of particular interest because it can cross the placenta and cause congenital heart block. Positive anti-nuclear antibody. Treatment: hydroxychloroquine, low-dose cortisone or methotrexate, xerophthalmia treated by artificial teardrops and corneal protection by soft contact lenses. Xerostomia may be managed by pathomimetic. Dry vagina is treated by lubricants, KY jelly. Number 2, Feltes syndrome. Arthritis, like rheumatoid arthritis, pancytopenia. Cortisone is a drug of choice. Splenomegaly with hypersplenism, no hepatomegaly. Seronegative arthropathy or seronegative spondylopathy. General features: we have 8, red eye, erythema, positive family history, HALA B27 except in Behçet syndrome, asymmetrical peripheral arthritis, central spondylitis and or sacroiliitis, more than peripheral arthritis, rheumatoid factor negative, هي اسمها rheumatoid negative, and last we have enthesitis, It's inflammation at sites of tendon insertion. And I'm not sure about the pronunciation, enthesitis. Okay. So to sum up, we have 8 features: rheumatoid negative, central, motor, and peripheral, and central joints are spondylitis or sacroiliitis, asymmetrical, peripheral arthritis, Halabi 27 except in Behçet's, positive family history, red eye, erythema, enthesitis, inflammation at sites of tendon insertion. Reactive arthritis, sterile arthritis occurs following an infection. Causative organism, chlamydia trachomatis, urogenital infection, Salmonella, Shigella, Yersinia, GIT infection, bacillary dysentery. Reactive arthritis, maybe just arthritis, but sometimes the clinical triad of Reiter's disease may occur. So what is Reiter's disease or Reiter syndrome? Male to female ratio is 10:1, form of reactive arthritis characterized by a clinical triad of 3. Urethritis, cystitis, conjunctivitis, arthritis. Urethritis, cystitis, conjunctivitis, arthritis. Arthritis is asymmetrical, oligoarticular, usually involving big joints of lower limbs such as knee, ankles, and feet. Sacroiliitis and spondylitis may occur. Can't see, can't pee, can't climb the tree. Treatment: non-pharmacological, the same as rheumatoid arthritis, rest and physiotherapy. Pharmacological, antibiotics for infections, NSAIDs for arthritis, and recurrent or chronic symptoms may need DMARDs. Behçet disease, systemic vasculitis of a known etiology which can involve large, medium, and small arteries and veins. There is an association with Halabi 5. Clinical picture, highly variable, with recurrence and remissions. Diagnostic criteria, recurrent, painful oral ulcer. 100% is present in all patients. Initial criteria for diagnosis require occurrence of at least 3 episodes of painful oral aphthous ulcers per year. To confirm diagnosis, at least 2 of the following must also be demonstrated: recurrent painful genital ulcers, which heal with scarring, 80%, recurrent anterior uveitis or retinal vasculitis, 60%, may lead to blindness, skin lesions in 60%, including erythema nodosum or acneiform lesions. Positive pathology skin test, defined as a formation of a sterile erythematous papule 2 mm in diameter or larger, appearing 48 hours following skin prick with sharp sterile needle. Other features: arthritis, non-erosive, asymmetrical, oligoarthropathy, involving big joints. Vasculopathy, unlike most forms of vasculitis, both arteries and veins of all sizes are involved. Venous thrombosis, Budd-Chiari syndrome, IVC, and superior vena cava clots. Aneurysms of pulmonary arteries may lead to massive lung hemorrhage. GIT ulcerations may occur anywhere in the GIT. The terminal ileum and cecum are common sites. It may be difficult to distinguish from inflammatory bowel diseases such as Crohn's disease. CNS, aseptic meningitis, strokes, cerebral ataxia, cranial nerve palsies, psychiatric disorders, cardiac, coronary vasculitis, and pericarditis. Investigations, non-specific, reflect inflammatory state, high ESR and C-reactive protein. Treatment, symptomatic treatment, NSAIDs for arthritis, thrombophlebitis. Systemic anticoagulant is often used in patients with thrombosis. Mouth ulcers, oral washes, topical steroids. Genital ulcers, topical steroids and colchicine. Anterior uveitis, systemic steroids, colchicine and cyclosporin. Anti-tumor necrosis factor therapy in severe cases. Ankylosing spondylitis, chronic systemic inflammatory disorder of the axial skeleton. The inflammatory process frequently results in gradual, fibrous, and bony ankylosing. It affects 0.1% of the population. Male to female ratio 3:1. Age less than 40 years. Onset after age of 40 is uncommon. Clinical picture 7a. Arthritis, mainly sacroiliac joints and spines. Back pain with prolonged morning stiffness. This stiffness improves with movement and exercise. The earliest, most typical site is sacroiliac joint. Sacroiliac joint, tenderness and decreased spinal motility. Peripheral joints, 30% are affected. Sometimes reduced chest expansion due to costovertebral joint involvement. Anterior uveitis, 25%. Achilles epiphyseis, tendinitis. Aortic regurg, 10%. Atlantoaxial subluxation, amyloidosis. Apical pulmonary fibrosis, and chronic prostatitis. Investigations: X-ray, sacroiliac joint, bilateral, symmetrical erosions, irregular joint margins. This is the earliest finding. Spine, erosions, calcification of the spinal ligaments, bamboo spine. Lab, rheumatoid factor, negative, elevated ESR and CRP, elevated alkaline phosphatase. HALA B27 in 95% of the cases, but it's not used for the diagnosis. Treatment, the same as rheumatoid arthritis. Idiopathic arthritis or colitic arthritis. Arthritis with inflammatory bowel disease, ulcerative colitis, or Crohn's disease. The patients sometimes develop characteristic skin lesions such as pyoderma gangrenosum or erythema nodosum. Pyoderma gangrenosum or erythema nodosum. Okay. Psoriasis, arthritis. It occurs in 8% of the patients with psoriasis. Pattern of psoriatic arthritis, asymmetrical. Oligoarthritis, the most common, and it affects more than 50% of the patients. Sacroiliitis and spondylitis, 20 to 40%. Polyarthritis, rheumatoid-like, 15 to 25%. Distal interpharyngeal joint involvement, 5 to 10%. Treatment like rheumatoid arthritis, but the role of anti-malarial drugs is controversial, as this may induce exacerbation of psoriasis. Whipple syndrome, more in males, and symptoms are MAN, M, malabsorption syndrome, A, arthritis, N, neuropathy and lymphadenopathy. Juvenile idiopathic arthritis, or juvenile chronic arthritis, or juvenile rheumatoid arthritis. 3 criteria must be met to diagnose GIA or juvenile idiopathic arthritis. Persistent arthritis for more than 6 months, onset under the age of 16, exclusion of other diseases which may cause arthritis such as septic arthritis. Classification. 3 major types are oligoarticular, polyarticular, and systemic onset or Still's disease. Oligoarticular or polyarticular. Most common, 60% of GIA affecting 4 or fewer joints, usually not symmetrical, involving large joints more than small joints. 2 types. Early childhood onset, younger girls, positive anti-nuclear antibody, and they are at risk of developing anterior uveitis, so routine eye examination every 3 months is recommended. Late childhood onset, usually older boys with sacroiliitis and HALA B27. Polyarticular, 30% of GIA, affecting 5 or more joints. Symmetrical polyarthritis, usually small joints more than large joints. This type of GIA is more common in girls than boys. Children with polyarticular GIA are at risk of developing chronic uveitis, so they should be monitored by an ophthalmologist. Systemic onset or Still's disease, it's a disease of under 5s, but adult cases may occur. Negative rheumatoid factor, fever, high with spikes up to 40 degrees daily, skin rash, splenomegaly, late arthropathy, so it's misdiagnosed as hematological disorder. So if you're gonna compare between oligoarticular, polyarticular, and systemic Still disease, frequency, the oligo, 60%, polyarticular 30%, Still disease is 10%, number of joints in oligo, 4 or less, polyarticular, 5 or more, Still's disease variable, female to male ratio, oligo 5 to 1, poly 3 to 1, Still's 1 to 1. Extra-articular manifestations, rare in oligo, moderate in poly, prominent in Still's disease, uveitis, 20% in oligo, 5 in polyarticular, and rare in systemic. Rheumatoid factor, rare in oligo, 15% in poly, and rare in Still's. Anti-nuclear antibody, 85% in oligo, 40% in poly, 10% in Still's. Prognosis: good, oligo, moderate, poly, moderate stools. And this concludes our chapter for today.